Right, good afternoon. Welcome, everybody. This is the final afternoon of our conference for 2025. Really excited to look at some of the innovations that we have come through, and we have been keeping notes of all the stuff we've discussed in the last day and a half, and really excited about this afternoon, some of the things that we're looking ahead towards in terms of innovations and stuff that can actually make a difference in child health. So welcome, everybody. Thank you for joining us. Thank you for being here on time. And we're going to kick off. We've got three speakers in the session. One is just still in the process of joining. So I'll introduce them each in turn. And then I'd like to just take some questions at the end of each talk, and then open up for a bit of discussion at the end if there's time. So our first speaker is somebody who Bryony Chisholm is got a background in pharmacy. She works at UCT in the Medicines Information Center. And this was actually recommended a discussion we had about what is the most innovative thing that we know of that's happening in the health system. And the idea of WhatsApp micro-learning was something that was discussed and mentioned. And then all of the advice took us back to everybody said, you got to get Bryony to speak to you. So reached out, and she very kindly agreed to talk to us this afternoon about WhatsApp microlearning, what it is, and the potential that we can use for child health. So, Bryony, thank you so much for joining us. Sorry to put you under pressure Friday afternoon. Really excited to have you with us and to see what you can share with us about WhatsApp microlearning. Over to you. Yep, that looks
Great.
great. Go ahead.
Okay, so basically what I'm here to talk about is just using WhatsApp micro learning for HIV training. And I will first do a little bit of the study data from the study that I did on it. And then I will show you some real world experience. We've just finished doing some 6MMD training using it. So I can show you the data on that. So the first we'll do the study data, and all of the photos that you see in this are photos taken of roads that I had to travel down to get to clinics that were in the study, just to give an idea of the distances. So a little bit of background, I think everybody knows this. There are lots of challenges to traditional training, which was centralized, getting everybody to central points and trying to organize accommodation and travel and venue costs and catering. And in a country that covers 1.2 million square kilometers, with many of our facilities in rural areas, that was hard. Beside all of that, the main thing was that it was very disruptive to clinic services, because we know that many of our clinics are nurse run, and for the nurse to then have to go and spend 3 to 5 days at the central town leaves the clinic without a nurse. More recently, we've had fantastic introduction of longer form virtual training sessions with the Knowledge Hub and various others. These also are time consuming. There's a lack of protected time in facilities for attendance at these things. Obviously, having recordings is better and solves that a little bit if people make the time to go and watch the recordings. But there are also infrastructural and tech challenges. Internet access is an issue in lots of the smaller places. And essentially, I mean, ideally, you need a nice big screen to be able to watch those virtual sessions. So I set about thinking about how we could get some training out to the people who need it, simply using what we have already. And we know that South Africa has over 100% cell phone penetration at this point. And WhatsApp, I mean, we all use it. It's ubiquitous with our adult lives as they are. So I designed a mixed methods cluster randomized study based in the Eastern Cape. I based it here because I wanted to show that if it to basically be able to say if it works here, it can work anywhere. We initially discussed doing it in the Western Cape, but decided on the Eastern Cape because it would be more generalizable for the whole country. So I included 50 clinics in 4 predominantly rural districts in the Eastern Cape. I only included nurses and community health workers. I excluded the doctors and pharmacists just because they are shared between clinics here. We didn't want to muddy the water between the intervention and the control towns. I did in-person recruitment, so I went to each one of the clinics, told them what the project was about, and invited people to participate. And we measured a number of outcomes, uptake and participation using obviously the numbers that we got, changes in knowledge using online questionnaires, which we did at baseline, and then straight after the training, and then 3 months later to check retention. And in those online questionnaires, we also asked quite a lot about the usability of it. And then we measured change in patient care. I went and did retrospective folder reviews comparing a year before the training to a year after on points that we trained during the training. So things like was GXP being done at women's first booking visits to the antenatal clinic. So I went back to all 50 clinics and did folder reviews there. And then I also did focus groups with the participants just for some lovely qualitative data. Just to kind of take a step back so that you know what I'm talking about. Microlearning is basically just little bits of information given via technology, most of the time by mobile phone. So during the study, I had 10 to 15-minute learning sessions held at lunchtime. Had one group for the nurses, one group for the community health workers, obviously for scope of work. And each lesson had 1 to 2 learning points taken from the national guidelines, and they were case-based. You can see one of the cases here on the right. And then we had a text, image, and voice note summary at the end of the learning points. The results were great. We had really good uptake. Obviously, I went to each clinic, which is not feasible on a large scale. But 80% of nurses, 3/4 of community health workers agreed at the clinics. Participation I measured using the 2 blue ticks of WhatsApp that we all watch, basically just to see whether they'd read, and I measured it during the live session. And then 24 hours later, a week later, and 2 weeks later. And by 2 weeks later, 96% of the nurses, I had around about 50% in the live sessions, and then going exponentially up. We had statistically significant improvement in knowledge comparing between the intervention and control arms at 3 months. And we also showed statistically significant improved patient care comparing the year before to the year after in the control and the intervention groups. And then the main thing that I found was that people loved it. So one of the questions in the post-training survey was, would you participate in this kind of training? We held it all year, once a week, and 98% said yes. And I had similar kind of experiences in the focus groups that I did as well. So that I finished, and the 2 papers, there were 2 companion papers in nurse education and practice. These 2, if anyone wants to read the full results, that was earlier this year. So then we moved on to getting it out there. And I was approached to do it for 6MMD. I was and I still am employed at UCT, but only part-time now, mainly doing this. So 6MMD, a little bit of background on that for those who don't know about it. It's basically just getting our very stable, eligible clients on ARVs to be able to collect the ART twice a year. So 6 monthly dispensing from the facility. Obviously, there's some very strict eligibility criteria for that. But South Africa introduced it in August with a phased introduction, phase 1 on the 1st of August, phase 2 the 1st of September, and then hopefully the whole country will be involved by the 1st of April next year. And there were various challenges to getting this training out to the people who needed it, who we wanted to start giving 6MMD. We had very short timelines. There was limited virtual training. And obviously the funding cuts have affected all of these things, the training and support at a facility level from implementing partners. So we got together and did a little collaboration and created some WhatsApp-based microlearning as an add-on to the virtual training that had already been done. And just to see how quickly it could be implemented. So just in this project, which we were admittedly trying to go very fast because we needed to get it out there, We first discussed it on the 10th of July, secured funding, started recruitment, made the sign-up survey. We're doing the lesson planning and training development in the background while we were recruiting. And registrations closed just over a month after we first discussed it. And the training started 3 days later. So basically 6 weeks from saying, let's do this, to actually doing it. Recruitment and signups is one of the kind of difficult things with it, or not difficult, just requires quite a lot of effort because you need people out there telling people about it so that they will go and sign up. So we had sign up using a SurveyMonkey survey, and we had various provincial leads and implementing partners all sending out the information and sending out the link to join. And I did a number of presentations on what it would look like, because it's new. People don't know what it's about. And we initially were only going to do one group. And by the 18th of August, we had 834 people and lots more asking. So we created a second group, and started that one on the 15th of September and had 700 people and still had people. So we did a third group, which started on the 1st of October and ended last week, which had 741 people. So just the demographics of who we got. You can see the provincial kind of layout. Western Cape is very small. That's because Western Cape is doing something slightly different. So they weren't pushing recruitment for this because their guidelines are slightly different. And Limpopo also, I think, were unsure about whether they were going to push it out. We had really good participation from Northwest. We had some great people recruiting there. And then Gauteng, quite big, quite a lot of kind of partner organizations and implementing partners, I think, just joining so that they could A, be part of it, and B, just to see what it was all about. And vast majority nurses, which we expected because they are the ones out there in the majority doing the work. And this is what it looks like. So you can see it's kind of progressed quite significantly from when we first started. We're now using polls, which becomes a necessity when the groups get bigger. And for 6MMD, it was a specific 8-week course, once a week lesson for 10 to 15 minutes at 1 o'clock or 1:30, depending which group you were in, and exactly the same. It's 1 to 3 learning points, mostly case-based, with polls, and then text, voice note, JPEG summary at the end of it. And each lesson was kind of a different eligibility criteria or comparing 6MMD to RPCSs and all of those kind of things. And this very rather busy table is the participation that we had. So this is combining all 3 groups with participation in each session. So live 1 hour was those who had read the messages within the first hour or who were in the group, then 24 hours later, and then a week later. And I'm not going to make you have to look through this. I summarized it into this. So this is all 3 groups and all 3 sessions combined. So we basically had just over half were within the live session or an hour. And by 24 hours later, about 82%. And by a week later, just under 90% had read the lessons. And then just this also is a little bit of complicated slide, but just to kind of get it out there that while this sounds very simple and easy to do, there is a lot involved in the background. So while it does sound like it's a quick thing to do, the creation of the lessons and the reviewing of lessons and getting expert review of the lessons, there is quite a lot that goes into the background that if you have the right people who have the time when it's being done, you can do very quickly. And the lesson design and the recruitment and training group creation can happen at the same time. So in conclusion, basically, WhatsApp-based microlearning, I mean, it speaks for itself. It's accessible, convenient, it's very acceptable to participants. It's extremely adaptable. It's not only for HIV, it could apply to any medical field and in fact beyond medicine, and it's quick to implement. And then I just end with acknowledgement and thanks to collaborators, the Department of Health, IAS, Palindrome Data, and especially Lynn Wilkinson, who I worked with to create the lessons and as a technical advisor. And obviously all the participants, because it's really nice to be in a group where there's enthusiastic participation, which we did get there, as you can see in those two little cell phone pictures. And then feel free to contact me. I know that I've rushed through this. That is my email address. If anyone does want to contact me, you are more than welcome. Thank you. Any questions?
Bryony, that's absolutely amazing. That's just brilliant. Obviously, coming from a background in pharmacy and the Medicine Information Center, you are well placed to talk about issues relating to adherence to medication and the whole 6MMD concept. How much of a technical expert do you need to do to run sessions like this? I mean, would you be able to run this on child health IMCI, or would you need to be an IMCI specialist
And
for to run a program like this? I'm not recruiting, but just asking.
yeah, no, well, I mean the yeah, I mean my background makes it I don't want to say easy, but makes it easier for me to be able to kind of know what to pull out from the guidelines. But anybody working in the field also knows, the main thing is to just pull out the points where you know that there are gaps. So kind of from a child health point of view, I wouldn't really know that. But if somebody were to say, okay, these are the points that we need to teach, then we can design the lessons to it. And basically, I I just with any of these with any of the lessons that I've designed, and I'm doing a bunch of different ones at the moment. Um, I'm perfectly happy to get a set of guidelines and to use those guidelines to make the the um the lesson, but then it does need kind of clinician input. So not necessarily a huge amount, just a read through to make
Mm,
sure, because I'm not a clinician and I'm certainly not out in the field, to read through and make sure that it makes sense from a clinical point of view and from a what you're dealing with out there point of view.
yeah, yeah. And were you able to get a sense of were there individuals at facilities or were there a couple people doing it together? I suppose you couldn't tell that because you're recruiting on SurveyMonkey, so you're not sure how clustered the individuals are.
Yeah, I mean, it's interesting that you asked that question because no, I mean, obviously, I don't know kind of generally, but I'm based in New Bethesda, and the clinic here was part of my study, and it's one of the things that they said to me. The community health workers said they all sat down at 1 o'clock when the lesson was going to happen. They all
Mm,
sat down together, and sat around the phone and did the lesson and then spoke about it. So it does happen. Whether that's happening everywhere, I don't know, and I doubt.
yeah.
But the thing with it being on WhatsApp is it's also one of those things that you don't have to be there at 1 o'clock. If
Mm,
you miss it, you can go in and if you want to be doing it with a group of people, you can say, okay, well, at 2 o'clock when we're all finished with the cases that we're busy with or whatever, we can sit down and have a look. So it does have that added benefit of being
mm.
available forever.
But what a wonderful image of the nurses sitting in the tea room at the clinic
Yeah.
with their lunch boxes out, and now one person's got their phone and that is
Yeah, I
absolutely
must say I was
amazing.
very, very, very happy to hear that, especially the
Absolutely
community health
amazing.
workers. I love the community health workers. They are so enthusiastic and so keen.
Yeah,
Yeah,
brilliant. Question from the chat. Have any of the users started to suggest or request topics that they want to learn about?
yes. So one of the sets of training that I'm doing is for the Medicines Information Center for the hotline, and I do certainly in that group because that is an ongoing weekly group.
Mm,
Um, we've said a couple of times, please tell us what you want. And yes, we've got lots of suggestions, and then I work on those. I mean, that's ideally we want to be teaching people what they need, what they want to know, if
Yeah.
they're struggling.
Yes.
Yeah,
Yes.
so it's very open to that. You've got to be a little bit careful when you've got a group of 800 people of just leaving commenting open,
Yeah.
because otherwise it just goes nuts. So basically, I only open up the group for 5 minutes at the end of the session, or until the 15 minutes is up for
Mm.
questions, and beyond that, I don't. But I do always say you can contact me directly,
Mm.
with suggestions or anything. Yeah.
And then outside of the clinical trial, where you were actually measuring practice change in the 6 MMD, Uta says, how do you measure engagement? They may have opened the message without really reading or engaging it.
Yeah. Yeah. So that is one
If you're
limitation.
not measuring practice change, then
Yeah. Yeah.
how do you know?
You're not really. It is definitely a limitation, and we all know that we've all been into WhatsApp groups and just opened it and not actually read the lessons. So there
Mm.
is that limitation that they may not have read it. So it's just a guide, really. It's not by no means a definite metric.
Okay. And you didn't provide free internet access. You let them use their own data or Wi-Fi.
In the study I did, I supplied data
Mm.
purely because I was also asking them to fill in a bunch of online surveys, so
Right.
to test the knowledge and to test the usability and stuff. But with all of these others, with 6MMD, with the hotline one, I'm doing a couple for a couple of other NGOs. We're not supplying data. It's also that's why it's on WhatsApp, because it's cheap.
Right. Brilliant. Bryony, that's amazing. Please, can you stay on?
Sure,
And
do
if
that.
anyone's got any other questions in the chat, if you could look at that.
Yeah,
There's nothing in
I'll
the
keep it in the
Q&A
chat.
at the moment.
Okay.
But yeah,
All
what
right
an
then.
interesting concept. Taking education right to the tea room in the clinic at New Bethesda, meeting the need of the people who providing the service. What do you want to know about? How can we provide that 15 minutes at 1:30 on a Monday afternoon? That really is amazing. So that's practical. That's right there. That's really is at the coalface. Super challenging, and I really want to use that and utilize that. So our next speaker is talking about a completely different innovation. This is not practically at the coalface, at the very individual, the point of contact. This is changing the whole ethos, the whole society. This is making making the world a better place. Um, and I couldn't believe this when I first heard about Planet Youth. I thought this is pie in the sky. But Planet Youth is a thing. And Gwen is a former colleague from the Western Cape, now back in Belgium, and she's an international representative for Planet Youth, and is going to tell us a little bit about what Planet Youth is, what it can do, and some of the international experience and the evidence behind how we're going to fix our society and make it better for children. So, Gwen, thank you so much for joining us. Um, hope that it's not too cold in Belgium. Um,
It's much colder than Cape Town in South Africa, which I'm missing dearly, but that's okay. I am that's why I've got my big scarf and my big jersey, and I hope nobody minds. Can you just confirm that you can see my screen in a slideshow mode?
that looks perfect. Thank
Okay,
you.
great. Okay, well, thanks everyone. So as they've said, I used to be with our colleagues in the Department of Health in the Western Cape, where I was heading the Violence Prevention Unit, and where we implemented Planet Youth after a very successful pilot in George, in the Garden Route, and I found the model so amazing that now I'm trying to scale it up wherever we can find partners who are interested in scaling up this model. It's in short, it's an evidence-based and community-led primary prevention intervention that aims to improve youth well-being. And the basic tenet of the theory of change, very simple, is if we focus on upstream, if we focus on primary prevention, we'll have happier, healthier children, and then we'll have happier, healthier adults and a happier, healthier society. And But for that, we really need to make the case for primary prevention. And we were lucky enough to be able to make it in our context. And I know that many people in many contexts are trying to make the case for primary prevention, which isn't always easy. But Planet Youth gives you a framework to make that case a bit more easily. Because investing in primary prevention and investing in evidence-based primary prevention is actually a really good investment, because the return is 12 to 18-fold. And there's a whole bunch of research that has proven that. Because what does primary prevention does, especially when it's data-led and evidence-informed, is that it strengthens protective factors and reduces risk factors for a whole bunch of things that children and families will have to deal with. That's substance use, violence in the home and violence in the community, and health. And I mean, and we can broaden this. And Planet Youth really tries to look at the whole array of risk and protective factors that affect children's well-being. But in order to push for more and especially better primary prevention, we really need to change the paradigm. We need to shift from this idea that primary prevention is free, that it's project-based, that we can do once-off little nice side events around. I'm sorry to say this again for those who have heard me say this before, but it's 16 days of activism. There's a lot of nice events that are happening in during the 16 days of activism. They very seldom lead to systemic change in terms of gender-based violence. And so we really need to look at this as a process. It's not soft money. It's not the little thing that you do on the side. It's not anecdotal. It can't be having a plan, having an idea, implementing it and evaluating it and never going back to assess it. You can't only focus on individuals, and it can't not have political backing. In order for primary prevention to work, we need to invest in it. It does cost money, not a lot, but it does cost money. It's a process. We really need to take both a systems approach, so look at the whole environment within which our families live, and we need to take a life course approach. So we need to understand that from birth to death, there is a whole bunch of things that happen that will have where we have spaces to intervene to strengthen primary prevention, because those are spaces where there is a risk that a person will be exposed, or a family will be exposed to a risk factor. We need to invest hard money in it. It needs to be evidence-based. So we need to really look at what we're doing and whether what we're doing works. We need to be very agile. So test, monitor, learn, adapt. It needs to take a community-based approach, and then it needs a political platform so that we can continue doing this work. But so in this context, what is Planet Youth? Just a second, please. So Planet Youth, it's been implemented in over 30 countries around the globe. It's usually a 5-year program, and where we survey the grade 8 and 9 learners in schools in the circles in gray, so every other year. And we don't have an intervention and then track the population that will have received the intervention, and we don't have a control population. It's really a universal approach. We survey grade 8 and 9 learners, so we never survey the same children, but it's a dipstick into the community to understand what happens and to understand whether community level interventions will have had an impact. Because as you'll see, if children drink less, smoke less, have sex later, sleep better, that means that we've seen an impact at a community level. And so that's when, once we have the data from the children, we can implement interventions that respond to that. Those are the years in turquoise. And then a year later, we run the survey again to see whether there has been a change. So it's surveying, acting very regularly so that we can very quickly adjust and adapt. And what do we mean when we talk about youth well-being? It's about strengthening their social connection, looking at their sleep, looking at their diet, looking at their physical activity, so sport, looking at how to improve a drug-free lifestyle, and then really focus on the positive aspects and on the strengthening. It's all about strengthening protective factors instead of focusing on reducing risk factors. It's really two sides of the same coin, but by focusing on good and on strengthening what's making children happier, it gives a massive boost to evidence-based primary prevention. So where has this program been implemented? It's been implemented in largely in the global north, and it's starting to be implemented in the global south. And that's because Planet Youth is a model that has to be self-funded by the government implementing the program, which means that in the global south, it hasn't been able to attract the same interest. But we've seen really good results in Chile, in Mexico. South Africa has now done 2 rounds of survey. We're working with the Uganda team, the Botswana team, and so we're having, and then lots of Eastern European countries. Increasing interest from many countries to look at this very simple yet impactful primary prevention model. This is the team. And so what has the data shown? The country where it's been implemented the longest is in Iceland. And it started because in 1998, the government ran a survey of its children, thinking that their children, I mean, Iceland is this perfect, really rich country in Northern Europe. And they thought, oh, our children are fine. Well, they weren't. 42% of 15-year-olds had been drunk in the past 30 days. So that's the red line. So they realized, okay, we've got a big problem. We need to do something about it. And that's when they started Planet Youth. So they got the community together and said, this is what our young children told us, or teens. So the teens had taken the survey in school. It's a 1-hour survey. What do we do to better protect them? And we've seen the data go down and down and down over the years, whether it's drinking, smoking, or cannabis. But at the same time, as we all know, there's new things emerging. And so now, since 2015, Iceland has seen a massive spike in vaping. And we've seen nicotine pouches appearing on the market, which also attracts adolescents. I mean, I remember when I was still in Cape Town this winter, I went to Pick n Pay, and there were just cute round little metal boxes that looked like sweets. And I asked the cashier what it was, and she told me, oh, it's nice little patches you put on your arm, and then it makes you feel good. Well, those were nicotine pouches. They're extremely addictive and extremely dangerous. And she was confirming that a lot of young people really liked buying them. So a massive risk that's a new product that's coming on our market that we have to be careful about. This is an example from an Eastern European town. In over 4 years, they've seen a lot of risky behavior go down. In Chile, they've run the program for 6 years and really integrated key components of the Planet Youth program in their youth policies. And then this is the results from the Western Cape. We ran the survey earlier this year with some good and some bad. I'm not going to go through all the data in detail. And if you want the data in detail, which you can have for the province, for the 18 communities in which we ran it, for the 124 schools in which we ran it, feel free to reach out to the Violence Prevention Unit. But so, for example, if I look at the kind of average data, only 66% of children sleep. So that those were grade 8 and 9 learners. 66% of children sleep on average 8 hours or more a night, which shows a big lack of sleep from 35% of our children. Only 49% of children participate in outdoor activities once a week. Only 50% of children think that learners are nice to each other at school. And then 15% were drunk in the past 30 days. And so this data is now used to disseminate it to local coalitions. So that's health, DSD, SAPS, local NGOs, and municipalities, and then trying to work together to better respond and to better tailor programs and services to families and to communities that will, in 2 years' time, when we run the survey again and when we survey grade 8 and 9 learners again, will have better numbers. And so on this note, this is really about continuing to swim upstream like those salmon, and continuing the journey for better primary prevention, which must be data-driven, evidence-based, community-led, agile, and focused on breaking silos, because we have to work together to make this happen. So, and here is my email address in case you want to be in touch. Thank you very much. Thanks, Dave.
Brilliant, Gwen. Thanks so much. So, how intense is the intervention? I know that it's lots of engagement with families, lots of community meetings, and you mentioned up front that it's not free and it's not cheap. What does it actually take to run a Planet Youth intervention in a community, so a peri-urban or a rural community?
So Planet Youth never wants to be an addition to what exists. It's really about doing what exists, but better. So, for example, I'm looking at what George did. So George organized parenting meetings at school in the evening, where they shared parenting lessons on the importance of making sure that they knew where the kids were on Friday nights, because that's a massive risk factors. We have, I can't remember what the data says, but I think it's close to 25% of grade 8 and 9 learners in the Western Cape are out at night after 10 p.m. on a Friday and a Saturday. And so that doesn't require a separate project-based intervention. It's government and communities working together to help parents put in place parenting mechanisms so that parents know where the kids are in the evening. That's one example. I mean, so what the data says is the biggest protective factor is parental involvement. And we know that in our context, that's extremely difficult, especially during the week. So it's really about how can we as government, and that's all departments, put in place structures and systems so that parents can take better care of their children and their teens during the weekend, so that children are protected from a whole bunch of risk factors. And then the other big one is sports. And so how can we increase sports in school so that children are busy in the afternoon instead of being out on the streets once school is over at 2:00.
Okay. I've seen some of the messaging from the Western Cape through the Planet Youth. It's quite well disseminated, and there's definitely great leadership from the politicians. They're always punching this idea. How similar is the obviously the problems are different, the context is different. The messaging in Vilnius and in Reykjavik to in George. George, there's at least 3 languages. So it's not a homogeneous community of teenagers. How similar is the messaging in different social contexts?
So Planet Youth never wants to use the same messaging across communities. So there has never been a message coming, like a communication package coming from Iceland and going to Vilnius and going to Chile and going to South Africa saying this is what you must say. No, what the model says is, we're going to help you understand challenges better by helping you listen to the voices of the children. And then we're going to help you and we're going to give you tips on how to interpret the data so that you, knowing your community best, can design interventions. And so the model, the messaging, for example, that came out of Planet Youth, and you might have seen the little fridge magnets as well that we used during the launch in July. All of those were completely developed by South African partners. It was a joint effort between government and NGOs. And it was never, so it's very much about what Planet Youth does is it gives you a frame within which to operate. It doesn't give you solutions. Planet Youth says solutions must come from the ground. People in each community know best what needs to be in place. We're just here to help you put a box, or give you the box within which you can see what can work and what can't work. And I mean, I see Notando is asking about what do you mean about test, monitor, plan, and implement. That's really about, instead of saying, okay, we think we want to roll out a massive parenting program for 2 million families over 3 years, and then we spend 2 years designing an intervention, and then we roll it out for 5, and then we realize after 5 years that maybe it didn't have the impact that we wanted. It's rather start small, choose 1 or 2 small communities, start with an idea. I mean, I think Bryony also spoke about that in terms of WhatsApp messages that are extremely flexible. When you've got a solution and a product that you can play with and adapt quickly based on what your user, what your partner tells you, it's bound to work better in the primary prevention space, because whatever solution you design at the beginning of a process is unlikely to completely respond to what communities need or want. And so giving you space to change is extremely valuable.
Brilliant. Brilliant. Okay, so we need leadership. This has been run by one provincial department, and now we need it to take it to national,
Absolutely.
and take it from there. Gwen, thank you so much. That's
Thanks,
absolutely
Dave.
inspirational. I love the concept. I love the fact that it's so international and yet so local. It is absolutely embedded in the community, but there is this connection to the bigger picture. Thank you so much. I really appreciate your sharing that and the perspective on that. That really is wonderful. Thank you for that. Okay, so our next speaker is Almero, whom I met I met online a couple years ago, when I was doing community training for resuscitation and intraosseous. I found this brilliant YouTube clip from 12 years ago with a very young looking Almero telling you how to do an intraosseous. And I play this video every time I go to clinics to teach intraosseous. I play the video, and then I send the clip to the nurse in charge, and then she plays it for the team. So a little bit of what Brian is saying is using WhatsApp, using your cell phone to use technology to take the message out. Anyway, that's a previous life. Almero is now got a career in innovations and doing things better, and the science of being innovative. And he wrote a thing a little while ago about optimizing and trying to, well, optimize. You can't optimize what you don't have, and I'm going to let him unpack that controversial statement. And Almero, thank you so much for joining us. Really appreciate it. Over to you.
It's a real big pleasure. Those videos follow me around. It was a 2-week sprint project where I think we did 20 videos in 2 weeks, shot on our own phones, edited on free stuff, with no particular equipment. And I think we're over 10 million views now, being used right over the world. So yeah, sometimes you can do a little something and it makes a difference. But what I want to talk to you guys about today is optimizing what you don't have. And please don't try and do it, but let's have a chat about it. All of the images in this is created with AI, and so there's no copyright on it. Can you guys see my presentation?
We can see it, but it's not in presenter view.
That is a frustration. Would you mind just bumping me off again?
Yeah.
Thank you. Okay. Let me just try that again. My apologies, folks.
Let's try that.
I'm just going to move this over. And then I'll do this again like we did before. And then we'll do... How's that?
Perfect. Looks great. Thank you.
Okay. You'll see me glancing up at my screen because it's not an alternative one. I am tragically interested in making the world a better place, and I think everyone in this call is as well. If we weren't, we have many other options for easier and more lucrative lives, particularly because most of the folks on this call remain interested in making the world a better place in a tough, resource-constrained environment and in one of the most complex and challenging industries or sectors in the world, which is healthcare and particularly public health. And what I want to talk to you guys about today is understanding whether when you're being expected to continue deliver positive value into the world, whether that expectation is reasonable or not relative to what you actually have to do it with, and how to make some decisions around that. So we're talking about that you can't optimize what you don't have. And if you have a look at that picture, those are 4 motorcycle racers. And I mean, they've got all the stuff, don't they? They've got their gear on and their boots, and they've got their helmets, and they're obviously having a race. They're not on any motorcycles. And I've certainly found myself in situations like that. And I'm sure many of you have too. And it's that sentence we hear, isn't it? We have to do more with less. Most of the time when we hear you have to do more with less, I have a physical reaction to that often when I'm told you have to do more with less. Because almost always the people telling me that I have to do more with less are in air-conditioned offices. And doing more with less often implies that me or my team or the people that we're working together with have to take on significant personal burden and sometimes harm in order to try and attain some kind of goal, which really is not reasonable or rational. And so often it is just wishful thinking dressed up in business casual. Now, for many of the folks, again, in this forum, we have experienced what it feels like to be told do more with less. But many of us have now or find ourselves in positions now where we might very well be the people asking that of other folks. And I think it's so important whenever we're trying to do anything new, and we've heard of wonderful new things going on now, whenever we're trying to do anything new or different, that we ask ourselves very realistically whether it's possible to do more with less or whether we need to find some other way to think about it. Because it takes what it takes. I mean, that guy is squeezing 1 drop of water out of a rock, but that's not the truth. It takes what it takes. The truth cares for itself. And physics doesn't bend to motivational slogans and what the organization wants. It also doesn't bend to our own desires. Because apart from the fact that we are often expected to try and do what appears to be impossible, we often have those expectations of ourselves. And I don't have to tell you folks that when we're dealing with vulnerable people and innocent people, kids, the degree to which we lay that burden on ourselves can be significant. But the reason for us carrying that burden does not change the facts of the matter or the impact that it can have on us. And so if we're thinking about, well, it takes what it takes, it certainly doesn't mean that we have to give up on trying to do good things. It just means that we have to be realistic about what we have and how performance enabling the environment around this so we can make good quality decisions. Because there's a line that you can't optimize across. So if we take teaching, for instance, what's the ideal teacher to student ratio? It's probably 1-to-1. You can see on the left there, if you're 1-to-5, 1-to-10, you're going to have good outcomes. Yes, if you're a good teacher, let's assume it's a good teacher. But if we look on the right there, that's just not going to work. So at 1-to-1, 1-to-5, 1-to-10, you're doing a great job. 1-to-20, you need some skill. Okay, you can pull this through. 1-to-50, you need to be very, very special. I'm talking about young kids now. You need to be very, very special, and you need really good supporting tools and help. But 1-to-100, 1-to-200, it doesn't matter how good you are. It doesn't matter the tools you have. You cannot deliver quality teaching like that. So while it certainly exists on a spectrum, there's a line called the critical capacity threshold. I'll still think about whether I want to take the risk to say what the old Afrikaans term for it is, but there's a line that you can't optimize beyond. It's called the critical capacity threshold, and it's critical to understand whether an endeavor is relative to that. So this is just what we're talking about. So any problem exists relative to the resources, capabilities, and capacity that's available to address it. And if you are below the critical capacity threshold, you just do not have what you need in order to deliver the result that you're expecting of yourself or that's being expected of you. So if we take the previous example, that teacher, if she needs to teach 200 to 500 kids, she's below the critical capacity threshold. If she's having some challenges above the line, so let's say she has 15 kids in her class and she's having some challenges, then she's above critical capacity threshold. Why is this important? Most of the things that we traditionally try or get told to do to increase efficiency and output are above the line strategies. So here we're talking about training, we just need to be better at our job. Efficiency, we need to cut out waste. PDSA cycles, QA, QI, CQI, audits, governance, blah, blah. All of these things only work above the line. They do not work below the line. And in actual fact, if you try above the line interventions, so traditional improvement interventions, if you try those below the line, you will A, make it worse, and B, you will cause more harm to the people that are trying to survive below the line. And so that's really important to know. Maybe just one caveat. We know that we're in a complex world. Yes, so you might be dealing with something. Let's say you're dealing with nursing education in the Eastern Cape. Some of those issues might be above the line. So the fact that so many folks have phones and that there is mobile internet access is above the line, and you can make that more efficient, for instance, by people sharing their phones. But some things might be below the line. So if you don't have someone that can create the content, or if people just do not have or can't afford the data, then you can't efficientify that really better. It's important because below the line, you need structural interventions, resources. Below the line, you have only two options. You either need to do what it takes to get the resources, capacities, and capabilities in that you need to get the outcome that you desire, or you need to adjust the goals that you desire. Above the line, so you should throw money at the problem or you should let it go. Above the line, you should not do that. Above the line, you have the resources that you need. And usually poor outcomes above the line is due to inefficiencies or maybe even some other more entrenched disabling factors. And so if you are above the line, you should not throw money at it because you're very likely to entrench poor practice and make it very intractable and difficult to fix later on. It's very important for all of us to pause whenever we're trying something new or different and try and have a critical reflection on where we are relative to the scale so that we can make good quality decisions about what it is that we want to do next. I certainly have experienced do more with less, almost like being gaslit. I've personally, and I'm sure many of us on this call, have taken significant personal harm and knocks from carrying burdens that I shouldn't have been carrying because it would never have been a realistic expectation. So what do? Well, firstly, you need to figure out where you are, and then you need to be honest and brave, and you need to match your approach to the reality. More on that just now. So if you genuinely can't have motorcycles, then you either don't have a race, or if that's not an option, so if we can't stop providing care, so if getting out of the race is not an option, well, then maybe we need to get on bicycles. Although I do acknowledge that these days, mountain bikes are probably more expensive than motorbikes and even many cars, but let's assume that they're affordable. So match your approach to the reality of your situation and make sure that there is a synchronized connection between what you want to achieve and what you have to achieve it with. And this is really it. So if you're above the line, you should optimize ruthlessly. Fix your processes, eliminate waste, build capacity. Don't hide inefficiencies. Don't hide inefficiencies behind claims of under-resourcing. And so here, honesty and courage needs to keep what you have accountable. On the other hand, if you're below the line, you have to add capacity or you have to adjust your expectations. Hire the people that you need, extend the timeline so that the project can get done, get better tools. And if you can't do any of this, then you must be brave enough to scale back or forego the expectations and pivot to something that can deliver results with what you have. Often we're just not sure. And if you're not, find out. Don't make assumptions and move forward and be the person saying, do more with less because you assume that they can. Or on the other hand, be the person not holding folks to account because you're throwing money at a problem that really is not a money problem. So when you're trying to find out, ask your staff, not consultants. Look at your outcomes, not just your financials. Don't assume what's going on. So finding out is it's not a cursory, quick glance, 3 emails in a WhatsApp. It's spending time and energy on making sure that you know what's going on, and then you react accordingly. What none of us have a fourth option where we pretend, if we just pretend hard enough that not enough, will then become enough. So hope is not a strategy. And this kind of hope, in the absence of evidence of any kind of precision, is very expensive denial because you won't get the outcomes that you wanted. You'll consume resources on the way to not getting the outcomes that you wanted, and you will erode your people on the way. That brings me to what we wanted to talk about. So, like any little group of brigands, like you see there, they can make do without resources, but they sure do like that treasure chest. I'm not trying to say that do more with less is always wrong. Sometimes, especially if you are above the line, that is what you should do. I'm not anti-efficiency or improvement science at all. But I think all of us can do with a little bit more time spent on reflecting where our desires and goals are relative to the resources, capacity, and capabilities we have to execute those, and then to bravely match our strategies and approaches to our resource reality. I'm very happy to take any questions.
Almero, thank you so much. That's really powerful, and it's so liberating to be able to push back against this efficiency narrative led by the guys in clipboards and air-conditioned offices. So what you said is, how do you know where you are? What if within the team there's a disagreement? Like one half the team thinks, yeah, no, we should do this. And the other half of the team says, no, that's too much. There's no way we can do that. How do you negotiate around that?
I think that's a really, really good question. And I think again, like so many things, victory or failure is determined before the peak of battle. So if we call that disagreement the peak of battle, if we had put enough time into empathic, constructive relationships with each other before the time, then the way to resolve that is easy. It means, let's say I'm pushing that we should do it, and Dave, you're pushing that we shouldn't. Then the first thing that I say is, well, maybe I'm wrong, Dave. Maybe you're right. Let's explore that. And you'll respond by saying, well, maybe I'm wrong. Maybe you're right. Let's explore that. And then together we'll look at it and we'll see what goes on. If despite that you still have uncertainty, then often the best way to do it is to either get some external objective, so just get a clean ear to listen and to look at what you're doing. And this is particularly important if we're talking about significant resource, time, effort, or energy spent. Yes. And then the other thing, and it's something that both of the previous, so Bryony and Gwen mentioned this, is the reality is that in complex adaptive systems, and we all exist. We swim in it. We're surrounded by complexity. Planning does not work. Linear games do not work. This isn't opinion. It's very, very clear evidence. And so when there is genuine uncertainty, sometimes the best thing you can do is to test and see what happens. Not the 5-year program for the love of everything that's holy. No. But if you're smart and you're thoughtful, then you can take a chunk. What is the minimum viable product? What's the minimum viable unit that we can test to test an assumption? If we say, well, we think that WhatsApp microlearning is going to be a really good way to do it, well, something that's minimum is it means that we need to know whether if we offer something, people actually engage with that.
Mm.
And so, well, then maybe there's an experiment we can design to at least test engagement. Because if we can't test engagement, if there's no engagement, then the rest isn't really worth it. So yeah, so I think that in a good place, we will be eyes for each other. And in the absence of that, and if uncertainty persists, get an objective eye and ear in and test components of it before committing massive resources to multi-year programs that's not yet proven or well understood.
Brilliant.
Maybe
Brilliant.
one thing also just to mention about that, often the people saying, no, we can definitely do this, are the budget controllers. They're not the consequence experiencers. And often the people saying, well, we can't do it, they're the consequence experiencers. They're not the budget controllers. So a general principle is that if you separate the decision-making power from the experience of the consequences of those decisions, then you're in a lot of trouble. And so one way to deal with that is to say that you cannot make a decision that has felt consequences in the lives of human beings unless one or preferably both of these following two things are true. Firstly, the decision maker experiences the consequence as well. We recently saw now how they are assigning bills of debt. So if you're a bad municipal manager and you like a droog gemaak, then the money that you wasted becomes your personal problem. So you have to connect real consequence to decision making. The other option is to say that the people who are experiencing the consequences of these decisions must have fundamental involvement and agency, not just theater, agency in how these decisions are made. Yeah. So connecting decision-making power and consequences of those decisions is incredibly important in this and many other contexts.
Brilliant. Awesome. Almero, thank you so much. That's really challenging. A lot to think about. Comments from Mashari, family physician. I can think of offering outreach programs, champion of CHPC. Yeah, that's a great example of something that we need to adequately resource. Make sure
I just want to mention in terms of champions, I think that the idea of champions is one of the most dangerous and toxic ideologies in systemic progress that exists. Not because of what a champion is, but because that innovations emerge from workarounds and pioneers or champions, but they sustain through institutionalization and owners. If you burden champions and pioneers by making them your sustainability strategy, you will lose the champion and the intervention. So it's very important for all of us to understand that in the early stages, pioneers, champions, workarounds, let's hack it, that's cool. But you, as an organization, you cannot allow champions to be your sustainability strategy because it is not a sustainability strategy. There, you have to switch to mainstreaming and formalization and ownership once you figure something out.
Brilliant. Okay, awesome.
Okay,
Almero, thank you so much. I really appreciate it. We're going to have to let you go. Another comment in the chat. Yeah, I wonder if you could just respond to that in the chat. We're going to move on to the next session, which is our research presentations.